I think we can start. Dear friends, this is our 10th webinar series on update of spine surgery. This will be on spinal deformity complications, and we have three distinguished speakers, and Professor Max Aibi will be moderating. I give the words to Professor Aibi.
Thank you very much. I think this is a very good idea to have a conference about this topic and to look to it from different angles of perspective. So we have neurosurgeons and orthopedic surgeons here, and we are talking about spine surgery, which is increasingly a known specialty. So I would like to invite Richard Assacker from Lille in France to give his first presentation about adult spine deformity correction and its possible complications. So please, Richard.
Thank you, Max. Thanks, Mehmet, for inviting me to such a highly orthopedic topics. So I'm a neurosurgeon, professor of neurosurgery in Lille University, and I owe all what I know today to my friend and master Daniel Chopin, who is ortho deformity surgeon, who taught me for 10 years the basic principles and how to achieve correction of adult spine deformity, degenerative deformity, and how to avoid such complication. So let's, can you see my screen?
Yes.
Yes, okay. So spinal deformity is a highly complex topic where first to get the corrective measures, you need to understand the postural features of your patient. And if you look to this standing EOS films, you can plan your surgery. And the second topic would be how to deal with your surgery with a minimum of complications. So you can see that such a patient needed a major surgery with a VCR and then a closed wedge osteotomy to realign the thoracolumbar area and restore acceptable balance. I would like to start with a typical case that we encounter very frequently. This patient, he's in 2017, asked to be seen by a senior spine surgeon for back pain. At that time, the surgeon says, you need some rehab and you don't need surgery. In 2028, he went back to him and he said, I have severe pain and start having some claudication, and the surgeon decide to do a laminectomy and fusion on this surgeon. The only thing that has been, I would say, underestimated is this patient is a Parkinson patient, and this was the result after laminectomy and L3, L5 fusion. Lots of mistake in this, and this is, I would say, the iatrogenic deformity on this patient who collapsed to the level above. This is called proximal junctional failure, even on the short segment here. And the mistakes were doing a full laminectomy, doing a short fixation with a flat hypolordotic fixation and end up in a disaster. And this is how it looks like. And this is how the patient looks like with the complete bascule of his trunk anteriorly. This patient was, he's still an artist. He's a German guy working in Paris. And look how miserable he looks like. So mistakes and iatrogenic deformity is a part of daily life. This is how he was. And this is his paint here. And this is what he drew me to illustrate how bad was his back before the treatment. You imagine this is an illustration of an artist. So I saw him in this situation here, and here are all the what we need to evaluate this deformity and do correction. So this is his CT, MRI. I won't go through details. And I performed traction on dorsal decubitus that showed a fair enough reducibility. And we end up by doing a VCR, placing a cage anterior, and realign this patient. I've done a mistake here by stopping at T10. Daniel Chopin taught me always, do not stop in the Parkinson disease on T8, go always to T4. And I did not forget that. But for once, I thought that maybe with an optimal alignment, I could save the superior. And look what happens. This is 4 days after the surgery. He was truly in a good situation. At 6 days, look what happens. He collapsed the upper instrumented vertebra. He presented PG failure, proximal junctional failure, and recur his pain. So I had to go to T4, and now he's fine. What I would like to send as a message is, please, your first surgery has to be well planned and well executed. This is a patient before, and here he is now, almost 3 years after the surgery. You see he looks like a Parkinson, but now he is much more comfortable. So we know roughly that complication in deformity, in adult deformity surgery, is 40% of the case, which is a very, very high, and reoperation rate is 26. And all what we're talking about are mainly mechanical complication that could be resumed by proximal junctional failure and kyphosis, distal junctional kyphosis and failure, or hardware failure with a pull out of the screws, rod and screws breakage. Of course, Mehmet knows very well this paper is a review of the literature, is a recent paper that everything is in, and you can see over 26,000 patients with a mean age of 60. We can see the number of complications around 35% and 20% revision surgery. We have all the systemic complication, the neurological complication, where Professor Lamartina will talk about the infection. And if you look to the implant failure, all the mechanical failure, it's a high percentage of mechanical failures. Here are the action and the measures to avoid those complications. And we all could go through details in this paper, but we don't have enough time to go point by point, but I will resume it later on. Second paper that I select is a paper from the team of Lamartina and with Pedro Berjano, who also does a similar publication on high percentage of complication and how to avoid that. So if as a neurosurgeon that came late to such a deformity, if I look as an observer, all what we're talking about, all what we're trying to do is getting the optimal alignment to get the less mechanical complication. So alignment and mechanics are linked together. And we've been told that we have to look to the spinopelvic parameters, of course, but the best alignment still has to be defined, the best alignment and the best simulation. So we have many schools, I would say, the Schwab, SVA, pelvic tilt, the mismatch between pelvic incidence and lumbar lordosis has some formula for that, the global tilt, the gap score with the European deformity group. Professor Lamartina is more and more talking about also the sitting position. So it's still evolved, but we need to get to formula that showed us what is the best alignment based on the age, based on the quality of the bone, based on the morbidity of the patient. So this is the basic that the SVA has to be less than 50, the pelvic tilt has to be below 20, and this is relative, and the lumbar lordosis has to match pelvic incidence, and this is well known. What we also focus in our department, and this is also because of Daniel Chopin, is how important is the distribution of the lordosis, not only getting an SVA, a global alignment that is below 50 millimeter, but also the distribution of the lordosis between L4 and S1 has to be around 70% of the total lumbar lordosis. So, and also Pierre Roussoli insists on how important is low versus long lordosis. In the coronal also, it's important to get the plateau of L4 parallel to S1. Once we get the global balance, the distribution of the lordosis, and these basic things, I think we can get a good alignment according to the pre-op deformity. The gap score also is more and more popular, and also the advantage is that gives you on the extreme pelvic incidence, very small pelvic incidence or very high pelvic incidence. This is seems more adaptable for simulating good alignment. So in our department, we try to through a multidisciplinary consultation have planned the surgery before, planned and simulate the surgery. You know, all the method of simulation. This is ancestral, where we with films, we cut the films and we know the angle of for restoring. Surgimap, everybody knows. Cheops, this is the one that we use for, but all of this, all about this is alignment, is geometrical alignment. We have no aspect of mechanics in this, but we assume that getting the optimal alignment will allows us to optimal mechanical distribution of the stress. So this is my the AKOPS that I use today, and we can see the simulation here. You can see that I bringing back the compensatory mechanism to normal. Here is the pelvic tilt that is switched to the green area on your right. And you can see that my patient virtually is falling down. So we try to simulate the osteotomies. This is a PCO, posterior colon osteotomies, on all the available levels. And you can see that the correction is better, but not enough. And we gradually go to get the optimal alignment. And we end up, because this is not enough, by doing a pedicle subtraction osteotomy. You can see here, pedicle subtraction osteotomy. We take the lowest one possible, L4, and we assume that we can get till 25, 27 degrees of correction of lordosis. Once we get this menu on how to virtually get back to optimal alignment, we execute the surgery, and we get what we planned for if the surgery is well done. So we won't have time to give you examples, but all this is planned in advance, and those are the post-op X-ray of the patients. So this is the patient before the surgery. Imagine how disabled is walking with the anterior vascular, and this is 1 year after the surgery on the right left. This is here also in a foreign country. They invite me for a minimal invasive work, and you imagine that this could not be minimally invasive corrected. So we've done osteotomy of T4 and T8 S1, and this is how he looks just after the surgery. So very quickly, to avoid PGK, there is many rules to this. And we know that PGK is related to the age, to the surgical approach. Is it open? Is it hybrid? Sorry. Is it open? Is it hybrid? To the rigidity of the construct, going to the sacrum, damaging the posterior element at the upper or at the proximal or the distal junction. So what we do usually is we try to preserve the posterior element at the apical, at the cranial and the caudal part of the instrumentation, do the PSO as low as possible, try to distribute the lordosis, get the optimal balance in one shot, and decide where to stop. Of course, we should not stop on the degenerated level or on the kyphotic region, and we could consider from time to time external immobilization. You can see here that the cranial part and the caudal part of the instrumentation, we did not take the spinous process, and we did not take the supraligamentous complex. Here is a Parkinson patient. In this situation, we use a double rods, and we isolate the site of osteotomy by a short construct, and we bridge it with the long construct above. Also, and especially for my colleague neurosurgeons, it's important to learn how to go to the sacrum. Sacrum with one screw in S1 is suboptimal, and it will lead always to a failure. So we should consider 3-point fixation, S1, LR screws, and ilium to get a nice and reliable caudal fixation. I will stop here because my time is over. I wanted to show you a case where everything were well done and we had lots of complication. Thank you all, and I'll be here for any question.
Thank you, Richard, for this excellent presentation. And I guess there are some questions from the audience.
Yeah, I'm listening if any questions.
Any questions? So, nobody? So let me ask something. I mean, at the moment, you know, there is a lot of discussion about this huge surgery in this severely deformed degenerative spines, and specifically in the Parkinson's disease, as you showed very, very well. The discussion is always now, is it really necessary to make such a big surgery, or are there alternatives? And there are people who now say there are alternatives. You can do the most important, resolve the most important clinical problem. Maybe this is the compression of the nerve roots or the spinal canal in this degenerative deformities in the lumbar spine, specifically the lower lumbar spine. Is it possible to avoid all these problems by doing just endoscopic decompression of the nerve structures without dealing with all these mechanical problems, what you may encounter with? So, I mean, I think it's important to send out here a message how far this is possible, or whether we don't really have data to support that. So what is your opinion, Richard?
I agree 100% with you, Max. This is why I think that the first surgery, if you are able to decompress without any iatrogenic consequence, this is what we should aim for. And I do endoscopic approach, I do minimal invasive tubular approach, and my first objective is not to realign the patient. What I have many examples or how important is to go minimally invasively, decompress the root in a deformed spine, in a highly scoliosis, and patient is complaining actually of radicular pain. The problem is he's complaining of radicular pain. He go to a surgeon who try to realign because he want to address the back pain and to decompress indirectly the nerve, and this is where the problems start to happen. I would never do a deformity correction before making sure that decompression is not the issue that we should address. For Parkinson, the neurologists are involved and deep brain stimulation, and usually the neurologists who push for realignment. So I agree 100% with you.
Yeah, I think this is very important, even more important for the future, because we are talking all about in the Western world, but not only in the Western world, also more and more in countries where you would expect more pathologies in younger people. We are basically confronted with the aging society, which is aging rapidly. We know that in Europe in 2050, that means 25 years from now, we have about 400% increase of male patients which are more than 80 years old, and 300% increase of women who are more than 80 years old. Mm. And I can only speak out of my own little experience, personal experience. I mean, I have a brother who has Parkinson. He's 78, and he has indeed a scoliosis. Classical. I mean, everybody would say that's what you have to do, but I mean, his problem is in fact mostly a radicular problem. So finally, I had to go against everything I knew until recently, and just do a decompression, minimal invasive, endoscopically, and he is quite happy, And in fact, I think we have to look at these alternatives because of the costs. I mean, if something goes wrong with this big surgery, these are enormous costs for the society, for the healthcare system. And everybody talks about increasing costs in the healthcare system. And yet we are confronted with this complex pathology where people really want to have a better quality of life. So I think it will be very important in the next years to clearly separate the pathology which may be accessible to endoscopic, minimally invasive surgery, and pathology which doesn't allow this option. I personally, for me, it's still difficult to really separate. Sometimes you say, okay, we do just the minimum as possible, and then you are punished because then something happens, and which then finally you end up with a long fixation, or you do immediately a long fixation or a correction, and then you are punished again, and then you say, oh, why I did that, why I did not try the other one. So I don't know exactly where to pull this line, but I think this is a very fundamental question.
So, Max, the patient you talked about, who does the endoscopic access?
Oh, there is, for instance, in our country, there is very poor endoscopic surgery,
But not you.
I'm not doing that. I mean,
so this is the problem. This is a problem. I think the problem is to have a spine surgeon who had a culture or all what we can do. This is why I learned to do endoscopic surgery also. I do endoscopic. I have been doing tubular access since, for a synovial cyst, for instance. I never fuse my synovial cyst from the first surgery. I go endoscopically. I'm sure that I'm not iatrogenically destabilizing the segment. And this is why, this is very good example, synovial cyst that you can decompress without needing to fusion. And I agree with you. Sometimes Parkinson comes to you with one root compressed and we realign two. The problem is we need a surgeon that does everything in the spine But today we have the big deformity surgeons that revise all what is done before, and the endoscopic surgeons that push the limit, and they have no education on deformity. They only know. So if you have a friend who knows how to do the endoscopic surgery, and you direct the goal of the surgery, that's fine. But I think this is an issue. We have to train our young generation to be able to detect and to execute something that could be done minimally invasively.
Yeah, I agree. And what we try. I mean, I'm now at the end of my career, but in our department, we try now to have people, at least 1 to 2 people, who do finally nothing else than endoscopic surgery, but they are part of a team where we discuss the cases, and then we say, okay, that's probably the best solution for the moment.
Exactly.
So any other comments, maybe from the audience or from the faculty?
Maxime, I have a small comment about this point.
Yes, please.
Very shortly. Excluding a Parkinson patient, we try to define the symptomatic level in case of adult scoliosis. Based on this, we proposed several years ago, a classification. We try to define when it's possible to perform a very selective surgery when the symptomatic level is far from the apex of the curve, or differently, more expanded surgery when the symptomatic level is in the apex of the curve. Different is if you have a very unstable, a very coronal or sagittal malalignment. In this case, we identify the cutoff. The cutoff in our experience is a lack of lordosis more than 25 degrees.
Yes, I think this is of course something we will have more and more to respect, that there are systems of classification, at least, which gives you a frame in which you can move. But I think what Richard said is very important, is that you have people in the team who really know the consequences, and also the technical way how you solve major deformities in the lumbar spine, which reflect also in the thoracic spine, and to basically be on the side of those who can this technique of endoscopic surgery. I think if you want to be successful in the endoscopic surgery, which is driven by technology today, by massive change of technology. I mean, we talk about endoscopic surgery since 25 years, but it has not really taken off. Maybe since 2-3 years, there is technology available which make procedures possible which were not possible until now. So I think it is very important to talk in an interdisciplinary team, and so the question is no longer whether you are a neurosurgeon or orthopedic surgeon, whether you are a spine surgeon who really understands the problem of the spine in terms of biomechanics, in terms of dynamics, in terms of muscular strength, and so on and so on. So I think this is, when we talk to younger colleagues, I think we have to tell them again and again that they have to solve this contradictions in the daily practice what we have, and I think it has been shown very well by Richard. Specifically the first case, what that means, in the first case you can even discuss why this guy did this stabilization, and whether the stabilization was finally the cause of all the secondary problems and not the decompression.
Exactly.
So, we can discuss for a long time about this,
Yes. This patient should had a minimal invasive decompression. A few weeks ago, I saw a patient from abroad who came for deformity plus lumbar stenosis. 2 years ago, I saw him here in Lille, and his main complaint was claudication. I decompress the canal with no deformity correction. And 2 years later, I saw him last week in the clinics. Actually, his posture changes because he's not on pain anymore. So he has not the same deformity than before. He's still somehow having some deformity, but very acceptable. So we have to make sure that we're not also, alignment is a. I saw a patient with acute this lumbar disc, and patients are bent anteriorly, and some surgeon would think that he had a postural problem while he's bending anterior because he's on pain.
Yes, it's I think we believe that all these degenerative spines, the lumbar spines, which are severely deteriorated in the aging population, that they have no longer a dynamic. Yes, they have still a dynamic. So that means if you start to stabilize everything in the spine, then you take away this limited dynamics, but it adds on per segment and segment. I have several patients where I tried just to do a minimal decompression, and they function pretty well, and I don't know what would happen when we have stabilized him. But anyway, there was a question I just realized from a colleague. Mehmet, can you see who was asking a question? I cannot see it here from here. So
we have one question from Murodjon who asked, how do you prepare patients for surgery with Parkinson's disease? Should I answer or?
Yes, maybe you can answer, or also
I would go quickly. For Parkinson's disease, first of all, I will check with his neurologist that his Parkinson is well treated and there is no indication for deep brain stimulation, and et cetera, et cetera. Then mainly he has to understand that this is a major surgery, lots of complication, and does it worth it? And from his side, is he ready to go for surgery with risk of complication? And finally, I don't know what Max, Lamartina, Mehmet thinks, but finally we have to do in one shot. If alignment is the issue, I'm not talking about somebody who's complaining of radicular pain. We have to do a global alignment and not stop in the middle of the, and optimal alignment is important. So, and have a good team for rehabilitation after surgery. I know one Parkinson that was unable to stand up. The alignment was good, was unable to stand up for 3 months. She fall down posteriorly, so she had to go gradually, and now she get better. But it's a major surgery, and as Max says, if we can avoid such a major surgery on such a fragile patient by doing a focal decompression, it would be much better.
Yes, thank you. There is also a question from SP, I don't know, and he or she asks, what's the name of the simulation software? I think you showed it. Maybe you can say it again.
It's the KEOPS.
Yes, the KEOPS.
The KEOPS that is distributed by Philippe Roussouli. I think it's called now, the company, it's called... just type on Google KEOPS, you will find it.
Yeah. Okay, there are some other questions, if I may. Why did you say that you should not end the construct at T8 in a Parkinson's patient? Can you address that?
Yeah. We don't know why those patients fail, but we know that a part of the risk of PGK is the muscle quality above the fusion. And we know in Parkinson, people, the Parkinson by definition had a tonus problem, had so an asymmetrical muscle tonus distribution between left and right. and we just know that the risk of PGK or PGF on Parkinson people, when you stop, even if the alignment is good, is very high. And we have many examples, and some like Daniel Chopin, like Pierre Rossoli. If you're facing a Parkinson and you have to go to an alignment, you have to stop at T4 or T3. Do you agree, Max? Do you agree?
Yes,
Claudio?
I agree completely. I have done quite a few Parkinson deformities, and I made the same experience at the beginning. Always, to avoid too long fixations, but there is no doubt you have to go to at least to T4 to make sure that you will not end up in a zone where you have this asymmetry of the muscle tonus. They fail. It is no question. It's also in the literature very well documented. I agree with that. So there is still a question, but then I think we should go on. Oh, that's the same as before.
Yes, the same, yes.
Yes.
T2
Okay.
or T4 is the same.
Yes. So if there is no any question at the moment, I think we should proceed to the presentation of Claudio Lamartina. Claudio, you are ready?
Yes, I'm ready.
So you shared your screen? Perfect.
Can you see my screen? Can you see, Max?
Yes.
Yes, yes.
Okay, perfect. Thank you, Max, for giving me the opportunity to focus this very interesting topic. Richard Asseker show us how powerful is the PSO, that means the pediculous obstruction osteotomy, in treating this kind of severe deformity, including Parkinson. But in the same time, Max Sebi focused on how important it is to try to reduce the number of cases in which we have to perform this kind of aggressive surgery. Mainly, the reason is the complication correlated to the osteotomy. And this is my topic today. I don't have any specific conflict of interest in this topic. Mainly, I want to include in this presentation the classical PSO, as you can see in number 3, but also the modified PSO. But basically, the problem is the same. I want to show you a couple of cases just in order to better understand why we perform this kind of surgery, even if we know very well how relevant is the risk of complication for this patient. This is a case of AB2, a case that means a case of adult idiopathic scoliosis. As you can see, there are close to 100 degrees of scoliosis, but there is also a severe thoracolumbar kyphosis close to more than 50 degrees. Obviously, in this case, there is a huge coronal malalignment. In this case, the patient correlated to this is not a simple problem correlated to the stenosis or disc herniation or something like this. Unfortunately, in a case like this, the problem is the deformity in coronal and in sagittal plane. This is the reason why in this case we have to perform a PSO, in this case at the apex of the deformity, as you can see here. In this case, we can restore a good coronal and sagittal malalignment with the 2 extra rod, but also with the key remain an asymmetrical PSO on the apex of the curve. You can see the result. You can measure the result. you can see how significant is the improvement in coronal, but also you can see that the sagittal profile, especially in lumbar lordosis, is very close to be ideal. In this case, you see the difference between after the surgery, and only this kind of surgery can achieve this kind of result. Another example, this is a case of AB1, that means a case of de novo scoliosis, is the case in which the scoliosis onset is late, very late. This is a very good example. Once again, a coronal sagittal malalignment, a severe both malalignment. And you see that how important is the correction at only one level. This is L3 vertebra, this is L5. You see at the end of the closure of the osteotomy, you see how close are the two lips in L3 and in L5. You can see in lateral the amount of correction is more than 60 degrees. You can see in the CT scan the amount of correction. This is a modified PSO actually. We call this corner osteotomy, that in this specific case in which the need of lordosis, extra lordosis is so high, this is probably the best way in order to achieve this kind of correction. You can see the immediate post-op in supine, but what is very important is 1 year follow-up. You see once again both in coronal and sagittal plane a very good alignment. The lumbar lordosis is very close to be ideal. Here you can see 3-year follow-up with the complete fusion of the osteotomy. But maybe if you want to understand why we have a significant risk of severe bleeding or risk of neurological deficit in PSO, maybe it's a good point to see step by step which kind of surgery is necessary for achieving this a good PSO. This is a cadaverical model. You can see that it's necessary to start to remove all posterior elements. That means spinous process, both lamina, facet joint, just in order to visualize, as you can see, the base of the pedicle, but completely you have to see the core, the dura, and the two in this specific case. This is L4 osteotomy. You can see L4 root bilaterally. You see how we can
decancellation of pedicles is initiated with a tab. Bigger convergent tabs are sequentially introduced in the vertebral bodies to create two cavities that are connected in the midline of the vertebra. Pushing curettes and rongeurs are then used to create a wedge in the vertebral body. The medial retraction of the dura allows for a section of the posterior body wall. Close-up view of the cancellation and a lateral wall exposure through the left pedicle. The right posterior wall is resected with a rongeur. Once the cavity is completed, the thin posterior wall is broken with a flat instrument that is placed between the dura and the bone, and then carefully hammered. The posterior wall has been completely resected. The lateral walls are accurately exposed and cut with osteotomes in a triangular shape.
Ok, that's good. Adesso aspettami che facciamo l'altro. È buono già, è buono già. Sciogolo. Bisogna vedere la piega. Perfetto. Basta. Basta. Guardiamo a raggi così. Prima di chiuderla e poi la chiudiamo. Ok.
At this point, the osteotomy is complete and can be closed with the bending of the Jackson table.
You can understand why when you perform a PSO, there is a significant risk of severe bleeding or neurological damage. Just because you have to manipulate the neurological tissue, dura and the roof, just because you have to remove a significant amount of bone. You can find this video in OOT platform. You can see more than this. This is only a part of this technique. If you look at the literature, you can see that the risk to have a complication when you perform a PSO is significantly higher if you compare this with the Smith-Peterson osteotomy. This is because of the technique. You see that you can have a significant amount of new neurological deficit, as you can see in this study published by Morbidity and Mortality Committee of SRS. You can have a significant new deficit, but also you can understand that there is a significant risk of hematoma. If you look at our registry, in 2021 and 22, we found 44 PSO for adult severe adult deformity. You see that the range of blood loss is very high. The standard deviation is in fact very high. The need of transfusion is significant high, even if the range is from 0 to more than 3 liters. You see also the amount of dural tear in this because of the manipulation of the dura, or the motor weakness because of the closure of the osteotomy can give it this kind of problem. There is no doubt. But once again, if you have to treat a case like this, there is no doubt you need this kind of surgery. It's impossible to treat, in my opinion, this kind of patient in different way or in a less invasive way. You see that there is a huge mass of fusion, maintaining the deformity and at the same time covering the all relevant anatomical landmark. This is the reason why you have help just in order to implant screw. Pay attention about L5 right screw as a very unusual direction. This kind of physical navigation, that means the guide can help you in this. but the key remain a PSO, L4 PSO. You can see at the end the result is very, very good, a very good correction in both coronal and sagittal alignment. Once again, if you try to compare pre-op and post-op, you can see that the amount of lordosis is very close to be ideal. We have a significant realignment in coronal plane. You see the patient is just immediate to the post-op. The last example is a case of multi-operated patient, but this is the final result, coronal and sagittal malalignment. There is a totally flat lumbar lordosis. But once again, in this case, in my opinion, the only solution remains the PSO. In this case, the PSO in L4 with a delta construct just in order to treat both coronal and sagittal malalignment. You see the result. And once again, if you measure the result, you see once again that the post-op is not far from the ideal. This is the patient before and after the surgery. How to prevent severe bleeding? In my experience, the best is to use this hemostatic agent in one side, just in order to control the bleeding, and then perform surgery in the other side, and vice versa. In this way, when you in one side have too much bleeding, you stop at that level. You put hemostatic agent just in order to reduce the bleeding. The other source of bleeding is the bone, not only the peridural plexus. But in this case, my strategy is the same. I put the hemostatic agent in one side, I work in the other side, and then jump in the opposite when the bleeding is too much. I think this is the best way in order to reduce severe bleeding. But in every case, you have to consider that for the PSO, at least you have to consider to have a bleeding of half a liter. What about the potential neurological deficit? Obviously, if you perform this kind of correction, you will have, there is no doubt, severe damage. That means pay attention during the closure of the osteotomy, check with the fluoroscopy if you are achieving too much correction, as in this case. But anyway, it's obvious that the main risk is, as in this case, when you perform a PSO, for instance, at T12, to pay attention when you close the osteotomy. Obviously, avoiding to achieve too much, but the closure remains the more the critical step of this surgery. You have to control with your eyes, with the neuromonitoring, if there are extra neurological damage. In conclusion, we have to avoid the entrapment of the dura of the root when you close the osteotomy. The osteotomy, just in order to maximize the bone contact after the closure. In this way, we reduce the risk of non-union. And continuous neuromonitoring is strongly recommended. Very often when you close the osteotomy, the bleeding stop. It is very important. It is very important to remember to be enough fast for avoiding too much bleeding. We have more bleeding in lower lumbar area, but in the opposite, we have less bleeding but more neurological risk, obviously, in thoracic area. Thank you for your attention.
Thank you, Claudio. This is, of course, a very complex surgery, and I wonder whether you always do double rods even in the first surgery. When you do the first surgery and you do an osteotomy in the first surgery, are you using double rods, or is that only when you do revisions of osteotomies or of previous surgery where you have to do an osteotomy?
Usually we implant 2 extra rods every time, also in the first surgery. Just because, as you know, when you perform a PSO, there is a significant risk of non-union. This means rod fracture, a failure and need of second surgery. This is the reason why we put in every case 2 extra rods.
Okay, I think there is a question here, which is Bushra Ahmed, I think. In old and osteoporotic population, don't the screw pull out, and people with movement disorder don't the screw pull out? I think, yes, this is an extra topic we can talk about, you know.
Okay, if I give a short answer, if you achieve a good sagittal coronal alignment, even if the quality of the bone is poor, there is no significant extra risk in instrument failure. The key remains to achieve a good alignment. Put screw cement in the screw is not relevant if you compare this in respecting a good sagittal coronal alignment.
Okay.
Max, may I ask
Yes.
Claudio a question?
Yes, certainly.
Yeah. Claudio, during your pedicle subtraction osteotomy, you never put a temporary rod from one side?
Only in case of potential instability.
How do you detect it?
The point is, I close the osteotomy, breaking the surgical table, not forcing in other way. When in the first step of this closure, I see a potential subluxation, immediately I put two short rods, just in order to avoid to have at the end a lateral
Translation.
displacement.
So you close your osteotomy by bending the table, and
Correct.
You contour your rods after.
Correct.
Yeah. Okay.
May I ask a question?
Yes, please.
Yes, thank you very much.
Thank you very much for a nice presentation. Are you using tranexamic acid for bleeding in PCO? Does those vary from patient to patient? Do you use a higher dose if there is a high risk of bleeding? And my another questions, do you use double rod construction for PCO area?
Correct. Answering to the second question, I put 2 extra rods just for this reason, in order to reinforce the level of PSO in which the risk of non-union is very high. Even if the best is to put the cage, if you put the cage, the risk of non-union is significantly less. In this case, the 2 extra rod is not so necessary. Different if you need the 2 extra rod, like a kickstand rod or a tie rod, for treating the coronal malalignment. In this case, is different. In this case, systematically, we implant 2 extra rod.
And tranexamic acid?
Can you repeat, sorry, the first question?
Are you using tranexamic
Tranexamic acid for bleeding in PCO. Do you use a higher dose if there is a high risk of bleeding for tranexamic acid?
Actually, I don't understand the question. Max, can you answer me?
Yes, if I understand well, you ask whether you use a higher dose of hemostatic agents in cases of expected severe bleeding.
Okay, thank you. Yes, I try to avoid it, to start with severe bleeding, because when we start with severe bleeding, the efficiency of the hemostatic agent decreases significantly. That means we start just at the beginning to try to control the bleeding in every way. With the hemostatic agent like Flocil, for instance, or putting gauze just in order to reduce the bleeding. But the key is avoid to start with severe bleeding. If you lose 1 liter, it's quite impossible to have a good coagulation function.
Okay. Any further questions? If not, I think Claudio mentioned the video, the total video about the osteotomy in the cadaver exercise. If you would like if you would like to, let me see whether I can share this. I cannot. So I can tell maybe it's, you can find this film completely and other films about osteotomy on the OOT platform, which is www.oot-esj, EuropeanSpineJournal.com. There you will find these films, and you can watch these films as many times as you want when you want to study these osteotomies. So, any other questions? I think we are already a little bit behind in the time. Then I would suggest that we take the third lecture from Erkan Ball, and he's going to talk about prevention of non-union and proximal junction kyphosis. Please. Yes, we can see it.
First of all, I would like to thank Tom.
What happened? He disappeared. So now we are back here.
Ercan, try to join again.
Okay, perfect. We can see it now.
I would like to thank the organizing committee for giving me to speak here. Today we will talk about a subject that is common concern for all of us spine surgeons. I cannot move my.
Sorry, click on the screen.
First, yes.
And then you can move.
Click, and now you go to the arrow to move it forward.
Ercan?
Yeah, my slide. Just a moment. My slide, my presentation doesn't start.
Can you close and open again?
Yeah. Okay. I close. Just a moment. Yeah. Spinal surgeons and architects are similar, however, with a small difference. Spinal surgeons do not have the chance to create a new structure. They mostly build their work on existing structures. PGK is identified as a deformity which developed due to increased stress on the upper instrumented vertebra in patients who have undergone posterior spinal fusion. Glattis et al. Defined Glattis for Glattis et al., PGK is a cop angle between the UIV and two vertebrae above it, 10 degree or above in adult spinal deformity. Helgeson et al. Described in adolescent idiopathic scoliosis for proximal junctional kyphosis. He says cop angle between the UAV and the vertebra above it 15 degree or above. And other authors described the PGK in adult spinal deformity populations. Proximal junctional failure, which is considered a more severe from PGK, has the risk of neurological deficits in addition to increasing deformity and increasing pain. The phenomenon has been well used to refer to as Topping-Off syndrome, proximal junctional fracture, proximal junctional acute collapse. Nowadays, we say PGF is a progressive form of the PGK, including UIV or UIV plus 1 vertebral fracture, subluxation between UIV and UIV plus 1, fixation failure, disruption of the posterior osteoligamentous complex, neurological deficit might require revision surgery for proximal extension of the fusion. And for Yagi et al., PGF as symptomatic PGK require any type of surgery. Austin says acute PGF as PGF of 15 degree or more with UIV or UIV plus 1 fracture, failure of UIV fixation or need for extension of instrumentation with 6 months after index surgery. General incidence of PGK in pediatric and adult patients has been estimated to be in range of 0 and 55%. Revision surgery for PGK is 10%. Early onset scoliosis has been stated to be the subgroup within the highest prevalence, and this prevalence was noted to be inversely related to age. Cutoff for PGA cutoff for PG proximal junctional angle 20 degree or more for the SRS self-image, significant difference. Kim et al. Reported that pain is more common in patients with PGK than in those without it. The angle of PGK is directly proportional to pain and inversely proportional to functional. While patients with PGK may be asymptomatic initially, Hart et al. Approximately half of patients who develop acute PGF may require revision surgery within 6 months after their index surgery. We have some risk factors that we can collect the risk factors for PGK tree heading. One of these is patient-related variables, balance and related variables, and surgical variables. In severe disc degeneration, low bone quality, age, and body mass index, previous trauma is the patient-related variables changes for PGK. In severe degeneration, there is a risk of developing spinal instability. Low bone quality has also been considered as a risk factor for PGK due to decreased in resistance to the stress in UAV. Some authors believe that the risk of PGK increases with age due to reasons, degeneration in the spine, osteoporosis, and muscle atrophy. Especially age is important for early onset scoliosis for PGK risk factor. Relation between body mass index and PGK has not been clarified. Previous trauma etiology has also been reported as a risk factor for PGK. This is a case operated for lumbar degenerative disease. lumbar degenerative disease. This patient we operated several times for PGK, Ross fractures, and later because this patient has osteoporosis, smokers, and is obese because this is a non-Indian factor for the patients. Another risk factors is balanced and related variables. Preoperative sagittal malignment might also affect the occurrence of the postoperative PGK. Postoperative correction is important for PGK. Overcorrection of kyphosis, overcorrection of the lumbar lordosis is important for PGK and PGF. We have some surgical variables. Risk factors for PGK. For example, large paraspinal muscle dissection in the UAV, disruption of posterior ligamentous complex, posterior ligamentous complex damage is the surgical variable risk factors. Combine anterior and posterior approaches, another risk factor. Rigid construction has also been reported to be a risk factor for PGK, and using pedicle scripts in UIV maybe would be a risk factor for PGK. Maybe we can use the hook and smoother transition for protect the PGK. Chrome cables and titanium rods as controversial. Hanetal detected PGK to be higher in a shorter time in patients using the chrome cables rods compared to titanium rods. In the same study, they also experiences high risk to breakage in titanium rods compared to chrome rods. Select UAV, despite the fact that there is no consensus in literature regarding the selection of the UAV. Kim et al. Reported UAV in the upper thoracic spine demonstrated a high rate of PGK compared to UAV in the lower thoracic spine or upper lumbar spine. And they say in same chapter, for 55 years and older, they didn't find a significant difference between the upper thoracic UIV or lower thoracic and upper lumbar. Boachi says no difference in the rate of PGK in the adult idiopathic scoliosis population with UIV T6 or above and those with below UIV T6. It is also proved that choosing a UIV at T8 and below may cause PGK. This is a case operated for a 16-year-old boy operated for Scheuermann kyphosis. After 3 months, PGK developed progressive over the time. We revisited several times. PGK development become easier when the instrument level is not chosen well, especially for Scheuermann kyphosis. And unfortunately, in the end, the instrument had to be extended to cervical vertebra. Is PGK deformity recurrence and or natural aging? This is an important question because radiologic findings in PGK are similar to natural aging process, including osteopenia, facet joint degeneration, discite loss, wedge compression deformity in the spine. And the underlying event of the PGF is often an acute structural event in the early postoperative period. Most common causes of PGF are fracture and soft tissue damage. Patient core studies say to us 7% had trauma and 7% had implant pull out in PGF. There are some classification for PGK. Yagi et al. Classified the PGK for type, grade, and spondylolisthesis for spondylolisthesis. This classification gives an idea for PGK. It does not provide any guidance for the management of PGK as well. And Heart International Spine Group organized the new scale for PGK, including the neurological deficit, focal pain, instrumentation problem, change in kyphosis, UIV, level of the UIV. Recommended the revision surgery for those with a total score 7 or above. Lafarge et al. Designed the new scoring system for PGK. They detected PGK rate be for 17% for 1 point, 69% for 5 point. Their scoring system, including the upper instrumented vertebra, lordosis change, lower instrumented vertebra, and age. How can we protect our patient with from the PGK? We have as a modifiable risk factor fusion level to a baseline kyphosis angle, instrument stiffness, composite metals, use of implants, distal osteotomies, soft tissue damage in UIV. Optimal sagittal balance using a transient rod might reduce the risk of PGK. A good evaluation is, of course, the most important step when evaluating a patient, including the comprehensive neurological examination, inspection, palpation for UIV, screen infection, and whole spine radiological examination. Of course, we determine the bone mineral density for every patient. It may be logical option to leave the top of the UIV sleeve a little loose when tightening it. However, if it remains too loose here, revision may be needed for example, in this case. In flexible spinning, if global balance can be achieved without osteotomy, extension of the fusion is sufficient. In rigid or severe kyphosis, maybe need Schwab 2 or 1 or 2 osteotomy. And in case of rigid kyphosis and anterior column compression, is it need the Schwab 3 osteotomies or another 4 or 5 osteotomies. The use of anterior interbody should be considered when significant anterior column defect is present for greater sagittal alignment correction. This is an cases 13 years old male. He has neurofibromatosis 1, operated for diastometamyalia in 5 years old. Operated with traditional growing rod and magic rod. His operation started 6 years old. Unplanned instrumentation revision. He has unplanned instrumentation revision 2 times for infection. Magic rod operation, the operation is started with magic rod operation in 6 years old. After the operation, he has 2 revision surgery for infection. After revision surgery, operated with traditional growing clot, but traditional growth clot is broken in here. 3 months after operation, and late operation, they changed the traditional growing growth technique only unilateral techniques. 3 months late after last operation, and later 6 months after last operation, he has proximal junctional failure. This is an Sanders and classification, hyperextension, rotor, and hyperflexion therapy. Some secretions were not properly not good insertion. Some secretions, for example, T7, T5. The patient developed, he had a drop syndrome and had to carry it with his hand. In this patient, we first removed the problematic screws and rows. Then we applied the holographic traction for 4 weeks. We reached the appropriate cup angle in 4 weeks. Holographic traction also helps to correct in the sagittal plan. This is first erect. This is 1 year later X-rays. This is clinical pictures for these patients. Another case is operated T3 compression and T8 burst fractures with C2 between the T7 pedicular instrumentation and lateral mass secret instrumentation. 4 months ago, he has iatrogenic traumatic kyphosis. He was in intensive care for a long time due to supraarachnoidal hemorrhagia. His gap score is very worse, and his secret is pull out, and T4 secretes placement is not very well for these patients. We operated these patients with corpectomy and posterior instrumentation with between the C7 and the L3. This is the pictures 2 years later. Another case is 17 years old female. He has operated for kyphoscoliosis scoliosis 4 times. She has low back pain. She has back pain and centers 8, register 4, and closed 3 radiate cartilage. But we have not X-rays for index surgery because she has operated another center. But we can see in post-op film shows that the lumbar lordosis is completely disrupted in here. The patient's lumbar system was then removed and thoracic region was instrumented for kyphosis in same centers. Then within 6 months, sagittal and coronal alignment got worse. This is a coronal alignment, and this is an kyphosis between the 87 degree. It is necessary to make a good planning to choose where to perform osteotomy and appropriate road counter. This is a perfect. This is a 1 year later X-rays. This is a pictures for patient 1 year later. Thanks for your chance speaking.
Thank you very much, Kam, for this pretty complex lecture. There is a lot of information which would have, probably we would need much more time to really go into the details. Is there any questions from the audience? Questions? Any comment from Claudio, maybe? Yes.
Actually, we should to differentiate PJK or PJF in adult deformity or in elderly, PJK in pediatric subject are two different, totally different topic. Max, you are right, is a huge topic. It's quite impossible to cover it. But anyway, speaking about, just in order to focus on only one point, speaking about the Schoerman image to have to treat a patient with 60 degree of pelvic incidence. Ideally, if your subject has 60 degree of pelvic incidence, the ideal lordosis should be more or less 60 degree. Suppose that you correct the kyphosis, the hyperkyphosis, to 40 degree, for instance. In this case, you create a compensatory lumbar lordosis close to 40. And you will have a inverted mismatch between the lumbar lordosis and the pelvic incidence. In my experience, this is the main reason why sometimes, not every time, in Schoerman we develop PJK. Just because we create this kind of new, let me simplify, sagittal malalignment. What do you think about this?
You have to put on the microphone. The microphone.
Ercan, you must unmute yourself. Yes, now.
Okay. Schoerman kyphosis is most complex spinal deformity, I think, because Schoerman kyphosis, in Schoerman kyphosis, we correct only thoracic kyphosis, but balances is changes with lumbar lordosis and cervical lordosis, because we cannot reach the ideal alignment for Schoerman kyphosis every time. PGK is higher or PGF is higher in Scheuermann kyphosis. I think this is the main point in here. We cannot elevate the lumbar lordosis and cervical lordosis with posterior instrumentation system because this is a complex balance in here for Scheuermann kyphosis.
Maybe Claudio may answer here, but in fact, in my experience, it depends at which age you operate these patients. You know, when you operate these patients in adolescence, that means around or shortly after the puberty, then I think that the upper thoracic spine and the cervical spine, as well as the lumbar spine, they have the potential to compensate when you do the correct in the thoracic, in the main part of the deformity, as when you patients where you don't have this compensation power, then it becomes very complex. Then you may end up not only with an upper deficiency in the upper spine, also in a distal junctional kyphosis. What does not happen when you usually not, at least I haven't seen that in patients which are young enough to have still the power of compensation. But once they are adult and there is already some degeneration, then we are dealing with this significant problem. That's my personal experience with that. I don't know what Claudio thinks, but...
Maybe another factor is aging is important for Scheuermann kyphosis. We can relate aging for Scheuermann kyphosis with Sanders or Risser or Menage, but aging is important point in here, I think.
Yes. I think, you know, I was quite surprised to hear that the junctional kyphosis in the upper thoracic spine is more rare than in the lower thoracic spine. And then, you know, you mentioned the paper from New York where they wrote about this in so-called adult idiopathic scoliosis. You know, the problem is that many of these people, when you look at these cases, what they have, these are not either adult idiopathic scoliosis. These are, in fact, de novo scoliosis or the other way around. So I think we have to be very precise with this kind of formulation because we are comparing apple with pears. You know, this is very clear. An adult idiopathic scoliosis has a complete different behavior from an adult de novo scoliosis. In fact, they behave very similar, like the adolescent idiopathic scoliosis, at least when they are in the middle age, between 20 and 45 or something like that. So I think we have to be very careful with these statements in the literature, which is based on a patient collective, which is not really a uniform patient collective, but a mixed one. I don't know what you think, Richard and Claudio, about this, but this is my experience when I studied these papers, and I have unfortunately to study a lot of them when I was editing a journal. You know.
If may I have a comment about this very, very hot topic. We should to consider also the cervical spine. The cervical spine is strongly correlated to T1 slope. If this slope is very low, your patient has to force in kyphosis because the daily life is in kyphosis, in cervical kyphosis, because you have to read, you have to eat. Your cervical spine must be in kyphosis. If your slope is too low, the risk of develop PJK is significantly higher. That means we have to pay attention not only in thoracic area or in lumbar area, but we have to start to evaluate what happened in the cranial part of a thoracic spine and in cervical spine. Another very interesting evaluating the risk in immediate post-op, the risk to develop a PJK is to measure in sitting position the distance between the C7 plumb line and the upper instrumented vertebra. If this distance is more than 11 centimeters, the risk of PJK is huge. If it's less, the risk is significantly less. But you have to ask a sitting X-ray. If you have a EOS, is easy. In other way, it's not so easy. But there is a huge topic, a huge field in which our knowledge is not so deep as our patient needs.
Yeah, I think you're absolutely right. Our knowledge is at least very mixed. You know, it's not like an exact science where you have a clear arrangements in an experimental setup. We are dealing basically, as we have seen now, again in these lectures, we are dealing very much with cases. So our surgery is very much a narrative science, case-based, and sometimes even we think that we have found a law or a principle, then very soon you will find a patient who doesn't fit in this system, you know. So we have to be very careful with our conclusions from individual cases, and that's the big problem in all these publications, because we have not really a standardized way how we can analyze and how we can evaluate these cases, because it's mostly not prospective, but it's after it has happened. And this is, you can see in these publications, you know, somebody says it's a high risk for an adjacent second problem, and the other one says no, this is not the problem. It is depending always from cases and how you define these cases. So we have to be very careful with these conclusions on principles of the spine. The spine is a very, very complex living structure. Any other questions? So I think
there is one question from Fatih Hadidi telling that should we undercorrect the kyphosis to avoid PJK in Scheuermann kyphosis? Undercorrect.
I think balance is whole, and we cannot reach a result by changing one place in Scheuermann kyphosis. That's why we should avoid overcorrection for PJK. Overcorrection is the big problem for Scheuermann kyphosis and other kyphosis problems.
Yes, okay. So I think we are pretty much through in time, a little bit longer, but very interesting discussions and excellent presentations. Thank you very much to the lectures. I think it's really worth to review this lectures when you are really interested in this topic, and I leave it to Mehmet Zileli to make a final statement and to close this session. Thank you very much.
Thank you, Professor Ayabi, and thank you all the speakers, Claudio, Ercan, and Richard, for very nice lectures. And also I thank all the participants. Okay, goodbye.